Good afternoon, everyone. Just call the meeting to order. It's 1 o'clock. Firstly, I'd like to introduce myself. My name's Andy Wright, and I want to get something straight from the beginning. I don't work for the NHS. I don't work for the people who are organising the consultation. I work for a separate independent organisation called the Consultation Institute. My job today, get it out the way, is to keep the meeting in order, to ensure that everybody has the opportunity to have their say, and also to allow the panel, who will introduce themselves in a minute, to have their say about everything. We're going to get some information, we're going to ask some questions. One very important point right from the beginning. Having said all of that, I'm independent, and my job is to make sure everybody gets the opportunity to be heard. So that includes you people, everyone in the audience, and also colleagues from the NHS. So no ground rules, just the simple rule of respect for each other. So when we're talking, allow people to finish and then ask questions politely. I would ask that we keep it polite. I know it's some very contentious issues, but we're here to discuss them today. So what we're here to talk about is the consultation on health services in the west, north and east of Cumbria. So before we go any further, is everybody in the right room? Always a great start. Thank you very much. Before we get into the presentations, I need to do some quick domestics, because if I don't do them now, I'll forget them. Fire exits. If we hear a fire alarm, there's not one planned. So there's a fire exit there and a fire exit on the way out through there. So we either leave from the back or through the front. Please leave in an orderly manner, and we'll congregate at the front so that we make sure everybody's out. Toilets just along this corridor, and I think that's it for all the domestics. I think I've got everything. We've got, as you can tell, we have professional sound equipment today. And part of the reason for that is that we want to have an audio record for everything that's happened during the discussions today. So, when we do come to questions and answers, I would ask you to speak into the microphone. So that will give us some order. Now, if you want to announce your name and the organisation that you represent, that's perfectly fine. But be aware that when you do that, it will be part of the permanent record. So if you don't wish either of those things to be stated, don't tell us. That's the simple rule. Okay. And that's about it. So, I'm Andy Wright. Call me Andy, right the way through this. I'll make sure everything keeps running. But I've spoken enough already. We're here to hear the panel. So what I'd like to do is ask the panel to introduce themselves. We'll start at that end.
Okay, thank you, Andy. My name is Dr. Stephen Singleton. I work for the Cumbria Learning and Improvement Collaborative, and also I'm currently acting as Medical Director for the Success Regime.
My name is Dr. Derek Thompson. I'm Associate Medical Director in North Cumbria University Hospitals Trust.
Good afternoon, I'm Lynn Marsland, and I'm the Director of Workforce and OD for the Cumbria Partnership Trust.
Hello everyone, my name's Caroline Ray. I'm Director of Primary Care for NHS Cumbria Clinical Commissioning Group.
Hi, I'm Rachel Preston. I am a GP lead for Cumbria Clinical Commissioning Group, difficult to say. I'm also a GP here in Penrith.
Hello, my name's Carol Davis, and I'm responsible for paramedic emergency services for Cumbria for the North West Ambulance Service.
Thank you. Christine Brereton, Director of Human Resources with the North Cumbria University Hospital Trust.
Thanks for those introductions. And without further ado, I'd like to ask Stephen to just give us a presentation to show us the key issues. Over to you, Stephen.
I'll come and get the microphone back. Thank you, Chair. My job is just to spend the first few minutes just introducing the public consultation document, introducing the topics which are covered by it, and a little bit of background at the beginning to set the context for the questions and discussions that we've all come to have today. The consultation is being led by Cumbria Clinical Commissioning Group. Caroline is one of the directors, as she said, but we act as a team through the success regime to have pulled this together on behalf of the whole NHS in the area. All the organisations in the NHS have been cooperating in the success regime, but it's the CCG who has this responsibility to consult. Now, the outcome of the public consultation, this process with the documentation, public meetings, stakeholder meetings, and a variety of other engagement exercise, is part of the decision-taking processes. There are other factors in taking the final decisions, including clinical, the money, practical considerations, and so on. It's really important that at this stage, we're talking about options. So no decisions have been made. We're here today to listen, as well as to give further information to your questions as much as we possibly can. During the period of consultation, which ends just before Christmas, all the responses coming in will be independently analysed, and then during January, early February, there'll be a period of reflection for us as partners in the success regime, reflecting upon what's been said during the consultation, what's been said about our preferred options, which I'll come on to in a second, other options that people have brought forward during the process where they think they've got a better idea than the things that we are proposing so far. And that period of reflection would then lead to formal decision-taking about the options for the future made sometime in the spring next year. We're hoping during March, but the exact timetable is still to be worked out. Now, just to make the point that I emphasise the point that public consultation is part of the process, it's not a referendum on the options themselves. So although we get lots and lots of responses, how we reflect upon those responses is, as I said, it's not a vote on any form of change. It's about having the discussion, airing the different points of view, and sort of moving towards a sensible decision as much as we can. Why are we doing this? In March, we published together a kind of clinical strategy, meaning a sort of medical nursing, a scientific, if you like, strategy for how we think Cumbria should move forward in the future. And the reason we need a strategy is because there's lots of challenges here in Cumbria. Overall, our health is not as good as it should be and could be. And we have inequalities in health between and within communities as well. We have a massive problem in Cumbria, which we share with some of the other public sector services, with industry, with various, the private sector, with universities and so on, of attracting people to come and work here. And it's particularly acute for us with doctors, both GPs. Fortunately, it's not too much of a problem, I think, Rachel and Eden, at the moment, but in a lot of the county, it's our biggest problem. Something over 20% of the GPs who should be working in Whitehaven, for example, the posts are vacant at the moment with no applicants after year-long advertising. But it isn't just GPs, it's specialist doctors, and it's not just doctors, it's nurses, pharmacists, other people who we have to attract here to Cumbria to work in our services. And it particularly extends to things like paramedics as well, doesn't it, Caroline? It's a real issue of recruiting the right number of people for the services that we have. Compared to many parts of the country, we use our hospitals a bit too much. People are getting admitted too much, and when they are admitted, very often for similar conditions, for similar populations, when we compare ourselves with other places, we have long stays in hospital as well. And you'll all be aware, there can't be anybody in this room who hasn't had the experience of waiting for a bed, you know, they've got a relative in the A&E department, or the kind of having a planned operation postponed perhaps, all sorts of issues related to the fact that we overuse our hospitals. There is a massive financial problem for Cumbria with the NHS as well. we're significantly overspending the allocation that's given to us. And that drives all sorts of other problems, including our lack of attractiveness to bring in other members of staff when we seem to be in constant difficulty of balancing the books, never mind anything else. And if that were not all bad enough, as you will have read in the papers or heard yourself, or if you're members of staff, you will know, the CQC, the Care Quality Commission, one of our regulators, has come and identified some services inadequate and others in need of improving. In other words, the quality of the very services that we depend upon is not what it should be. And the uncertainty that we have isn't helping. We need to remove some uncertainty about the direction of certain services. We need to tackle some of the difficult issues, and we need your help in making decisions. And that uncertainty cuts in all sorts of directions. It was with the regulators, with the people who allocate us money, and we want to argue for more money. It's to do with recruitment. It's to do with how the services develop in the future. What we have settled upon in that strategy that we published in March is a different vision for how Cumbria could work. That we've tended to try and run traditional small, medium-sized hospitals as if we were anywhere else in the country. When in fact, what we need to be is excellent at providing the kind of integrated health and social care that rural and remote and dispersed populations need. There is a difference if you live in a rural market town like we are here today, from being in the suburb of a big city. There is a difference for the 100,000 people who live along the West Coast, who are a long way from the next nearest hospital in Carlisle, which itself is a long way from a regional centre like Newcastle or Middlesbrough. So our vision is that we become a centre of excellence for that kind of healthcare, and by pursuing that vision, help solve some of our problems, for example, attracting staff who want to be part of that journey to that vision. The foundation, if you like, the building block of that strategy that we published in March is the idea that each community, natural community, which about 20 to up to 70,000 people, need joined up care. And a bit like before, and I know from lots of experience of talking to many audiences, if you haven't had the unfortunate experience of waiting for a bed in A&E or waiting for some service, you will definitely have had the experience yourself or for a relative of telling the same story to 3 different members of staff who apparently, although they all work for the NHS, appear to work for 3 entirely different organisations that don't talk to each other. We don't seem to manage simple joined-up care. And when people are needing care in their own homes or close to their own homes, when the GPs are seeking help from specialists and other support, when we're trying to work together with social care to arrange packages for older people, for people who are vulnerable because of their long-term conditions, we need services that work together. So the NHS, social care, the voluntary sector, as I said, care at home or care close to home, it all needs to work better than it is at the moment. By comparing ourselves with other places and looking at other places that have achieved this already and looking at the good things that are going on in Cumbria, because it's not all bad, we can put together a plan that says if we did all of this systematically for everybody all of the time, actually, we would need less admissions to hospital. We could get people out of hospital quicker and back into their own homes. So that big problem of overuse of the hospital could be tackled. If we were talking to each other better, if the care was integrated better, we wouldn't be wasting time, wasting both the time of the professionals, but more importantly, the time of the patients and their carers and their families, of not getting things organised in the right way at the right time and so on. So there are benefits for the system, there are benefits for us as professionals, but most importantly, there are benefits for you as users of the services if we can pursue that as the very foundation of our strategy. The integrated care communities, plus the changes that we're talking about, basically add up for us to safer services which are higher quality, which we can sustain better in the terms of attracting staff, being affordable, and so on and so forth, and look like the 21st century, rather than looking backwards to the 20th century. However, it isn't just about building on what we do already, joining things up, being integrated, having a strategy. There are some potential service changes, which is what this consultation is now about. And they are bits of the jigsaw that we need to put in place, partly to enable the rest of our plan, and partly, as I said, to cover things like the problems of money, the problems of attracting staff, and so on. So what are they? In children's services, we're looking at three options in terms of trying not to provide the same services in two small places, which it's just becoming impossible from the point of view of the specialist staff that we need. It's not as safe as it needs to be, and so on. And you can see there the three options that we've got. In option one, which is our preferred option, there would be assessment of children at both the Cumberland Infirmary and West Cumberland Hospital. But overnight at West Cumberland Hospital, we would only be looking after children who are, if you like, being supervised at a nursing level. All the sick children who need to be in hospital overnight would be brought together in one place. Our proposal is that would be the Cumberland Infirmary. There's a number of advantages of that. The Cumberland Infirmary already has different interdependencies of other specialists. And of course, for the very sick children who don't recover as we would hope, it's that much closer to Newcastle, where the very specialist centre is as well. The two other options we're considering is to have inpatients only at the Cumberland Infirmary, with the assessment at both sites during the day, and a full consolidation at the Cumberland Infirmary is the third option. And as I said, our preferred option, which happens in all of my slides now, is the purple one at the top there. Maternity services, again, at the moment, traditionally, we've had two really quite small services in two hospital sites. In fact, if you have a league table of size of maternity services, they're two of the 7 smallest in the entire country. We got, again, because of staffing problems, because of the perception and expert advice that we've had, that we will not be able to sustain the services as they are over the next 5, 10 and 15 years. And we don't want to have to consult every couple of years. We're trying to think about our strategy supported by services that will last us into the future. The three options there are to continue with consultant services both at the Cumberland Infirmary and West Cumberland Hospital. That's not the same as status quo, because that option takes higher risk pregnancies, women with higher risk pregnancies, all to be at the Cumberland Infirmary. The second option is to say, actually, we can only really have one consultant unit over the period, sustainably for that time. We should have that at the Cumberland Infirmary, and that, for choice purposes, we would have a midwife-led unit at West Cumberland Hospital. Now, that's the sort of option that's used in Wales, in Scotland, in other parts of the world. We've looked at models from all over the country to see what would be the best idea. And for lots of different reasons that we might want to discuss earlier, but as I said, it's to do with staffing, sustainability, the interconnection of services. You can't really have a maternity service without a paediatric service, for example. Both of them depend upon anaesthetic services when there's an emergency. So we have to, each bit of the jigsaw has to fit with the other bits that we have as well. Our preferred option for choice is to have the midwife-led unit, and the third option is full consolidation again at the Cumberland Infirmary. The community hospital, inpatient beds, not the hospitals themselves, but the inpatient beds, have been looked at for possible consolidation as well. Now, again, there are different reasons driving this, not least of which is our complete understanding that whilst we need beds for people who need beds, being in a bed is of itself not a good thing. We want people to be as mobile as possible, back in their homes if possible, and so on and so forth. And we've been looking at the way we've got the community hospital beds spread across the county at the moment, the north, west and east of the county. And we've got 4 options, as you can see, about consolidation. And the preferred option is consolidation on 6 hospital sites. Now, for us locally here, the biggest impact on that would be not here in Penrith, but up at Ulston. It's important to emphasise that we're not talking about closing the hospitals. We're talking about using that resource to maximise our ability to do that integrated care community, that idea that within a hub in any one community, we do need more things to be going on. We don't use the existing resources we've got as much as we could for things like outpatient diagnostic tests and so on. From all of our communities, including here in Penrith, up in Ulston, further down south in the Eden Valley, across into the Lake District and so on, loads and loads and loads of people every day are making unnecessary trips to the Cumberland Infirmary to get a test or to see a specialist. We absolutely believe that we can use the resource differently so that, for example, using video conferencing more, getting the specialists to travel instead of us as patients to travel, that places like Penrith Community Hospital, Ulston and so on, can be used as the centre of how our integrated care community idea works. Now that does require us thinking about how we use the beds, particularly again, as you will have read and you will know, staffing of those is a problem as well. And we have to think about when we need the beds, they're properly staffed and properly available, and how could we consolidate them? And that's the argument behind those options. Emergency and acute care has to be looked at. We've made some changes. Again, you will have read about this in the newspaper between particularly the West Cumberland Hospital and the Cumberland Infirmary, but also we have services like the assessment centre here in Penrith that all connect as a network for urgent care. They connect with what the GPs during the day do with urgent appointments and visits. They connect with the out-of-hours service. They connect with the ambulance service. And they connect with the various places you can go for either assessment or into A&E. The A&E hub bit of that service is clearly vital. And our preferred option is to maintain that 24/7 at both sites. But as you can see, there are some options where we're thinking about the possibility of not an all-comers A&E, but an urgent care centre at the west compared to the Cumberland Infirmary, and daytime A&E, or a full urgent care centre as options. But you can see again, our preferred option is that A&E hub exists on both hospital sites. Stroke services are a little bit like the way cardiac and heart services have changed. Oh, sorry. If I step further back, can you see? Yeah. Thank you for highlighting that. Stroke services are a bit like the way we've changed heart services in the last few years. Increasingly, when I was a GP, not very far from here, a few years ago, and it's not that long ago, stroke was one of the things that we sometimes managed in people's homes. We would say to people, well, do you want to stay at home or do you want to go to hospital? As if, it didn't seem to make much difference. We absolutely now know that we should treat a stroke or a mini stroke a bit like a heart attack. It's a brain attack. We need to do something now, and we need to do it with a specialist team. And we need to do that specialist care not just in the first few hours, but overwhelmingly we've learned that what happens in that first week really matters as to whether you both survive and, perhaps more importantly, get home after your stroke again with as limited disability caused by the stroke as possible. We absolutely need one of these what's called hyperacute stroke services, and that's just doctor jargon for the very first few days after a stroke. It's really important, this. It's like, again, we used to just, particularly for older people, if you had a heart attack, we'd give you pain relief and hope for the best. We now know that there are things we can do to make a difference. Stroke is just the same. But again, we have less than 2 full-time equivalent leaders of stroke services across our 2 hospitals at the moment. We want to attract specialist nurses, specialist speech therapists, put them in one place, staff a single unit to be that first week specialist unit. Well, we can only have one of them. And again, a very small number of people who have a stroke need neurosurgery. So the best place to put it, with the connectedness of intensive care and other services and the nearness to Newcastle, is the Cumberland Infirmary. So our preferred option here is the dedicated unit at the Cumberland Infirmary. Now, I have to talk briefly about the money, and then Andy, I'll stop shortly. We currently overspend by about 70 million. So that 70 million pounds of somebody else's money gets spent here in Cumbria above our allocation. If we do nothing to reverse this trend, the modelling shows that we'll be overspent by something like 160, 170 million in only a few years' time. We reckon that the overall strategy I described at the beginning, and new ways of working and everybody being more efficient, could save quite a lot of money. You can see it there. And new ways of working, the telemedicine, not using the hospital in the same way, and so on and so forth, that can save us another 45. These particular changes aren't about the money in the huge way that the overall strategy and the efficiency is. There are some savings to be got out of these clinical changes, but as I've described, they are much more about us all in Northwest and East Cumbria having access to kind of 21st century modern services, attracting staff in. That's the real focus of these changes, rather than the money, which we're going to have to save with the overall clinical strategy. If you've listened to each of those options, you'll be clocking them up and see it has quite a significant impact on the West Cumberland Hospital, potentially, if all our preferred options are what are decided at the end of consultation. But it's not all things moving away. There is a plan to return some of the really acute, sometimes we doctors call it the hot surgery, the stuff where it matters, how quickly you get things and who's doing it. A couple of years ago, as a way of saving lives, and it did save lives, the hot surgery and the trauma pathways were changed so that everybody was going to the West Cumberland Infirmary. The trouble is, a policy that says everybody means a small child with a fractured wrist, for example, does a long journey to the Cumberland Infirmary for a fracture clinic or to get a pot on, when that can all be dealt with locally. In fact, you probably heard on the news yesterday, they probably don't even need a pot on in the first place for some of these injuries. So saying all trauma goes to the Cumberland Infirmary has taken it too far one way. The West Cumberland Hospital, the new West Cumberland Hospital, with its ensuite rooms and so on, is the perfect place for doing planned complex surgery. So actually, one of the ways of fitting all of this jigsaw together is to take some work out of the Cumberland Infirmary and put it into the West Cumberland Hospital, because that's the best place to do it for all of us as Cumbrians. A major new diagnostic suite is planned for West Cumberland Hospital, and that's again part of this business. I was in Maryport the other night, and we were talking about the 30-odd thousand journeys of just the people in Maryport to get out of Maryport for diagnostic tests, these specialist opinions and so on. We can bring a lot of that activity much closer to people's homes so that actually more people end up being treated at the West Cumberland Hospital than before. So I've skipped through it all. I'm conscious. I had eye contact with some of you at a point where you thought, I want to talk about that bit. That's the bit I want to talk about. I'm sorry for just kind of skipping through it, but I hope we've given us maximum time, Andy, for questions.
Thank you, Stephen. A lot to think about there. A couple of comments before I start to take your questions. We're joined in the audience by colleagues from specialist NHS services. So the panel will answer the questions, but if there's anything specialist, there'll be some answers coming from the audience as well. Just quickly ask those people that are here in that role just to identify yourself by showing hands. Okay, we've got them in here. Thank you very much. Right, and also to say that the consultation document is all here, so anyone that hasn't had the opportunity to read it, it's there for you to look at, and it tells you other ways in which you can be involved in this consultation. So thank you very much for listening. Thank you very much for Stephen for a very concise and to the point presentation, but I'm sure it raises a lot of questions. So at this point in time, it's over to you. I would just say that we've got a lot of people in this room and we've got a lot of questions. So if you could keep your question as brief as possible and to the point as possible, and I'll make sure the panel answers it. And there's the opportunity to come back. The other thing to say as well is that we will have a roving mic. So when you get that, please speak to that, and then we'll get it all recorded. So, questions, please. Show of hands, who's first? Gentleman down at the front here.
If we've got all these experts here sitting in front of us today, right? If we've got all these experts sitting in front of us here today, why do we need Sir Neil McKay to be in charge of it? How did he come to get the job? Was it advertised? And what is the salary? Bearing in mind his qualifications, he received a knighthood for services to the NHS. And it was knighted as a decision when he was a chairman of East Anglia Strategic Health Authority to award a contract to a private company to run Hinchinbrook Hospital at Huntingdon, which was halted after 3 years, with a £54 million deficit that had to be bailed out by the taxpayer. So why do we need somebody of that calibre, or you could say professionalism, which the professional word just means somebody who earns his living, and when he got paid redundant from that post he held, he got £1 million, £400,000 in redundancy, and £600,000 out of a pension pot.
Thank you very much for the question. Very well put, very articulate. I'd like to ask Stephen to take that.
He got the job by appointment. I think it's worth emphasising that West, North and East Cumbria is one of 3 places in the country. The other is North Devon and parts of Essex, which have been designated in this success regime. My personal view is that's a bit of Orwellian doublespeak, because it's although we're talking about success of the future, the reason that we're in the success regime is years of inability to solve our problems, both financially, performance, as I said before, CQC, worried about some quality. So whilst all of us are very proud of the services we provide, we needed to catch up with some other parts of the rest of the country. Now, the reason he was appointed, rather than one of the leaders already here in Cumbria, was to have an independent focus on driving forward a new strategy. And I'm happy to talk to you afterwards about the Hinchinbrook stuff.
Sorry, can I come back to you for another question? There's a lady there asking you a question. I will come back to you on that one, okay? That's a promise.
My question is directed towards the ambulance services. I appreciate the need for change in the paediatrics and the maternity, and I am aware of the importance of the hyperacute stroke unit. But this has considerable implications for the number of ambulances and the number of qualified people that you have working on those ambulances. Have you got any plans to increase the number of ambulances available and the qualifications? Because a sick child to get to Carlisle is actually of enormous concern. Okay. Quickly, can you answer that for me, please?
Yes, I can. We've already increased our resources. As Stephen had already said, over the last 2 years, we have seen some transfer of services from West Cumberland to CIC. To be able to, there was a bit of work done beforehand about what we expected in terms of the number of additional transfers on top of our own emergency work. And that's actually worked out at about, I've got the figure here, an additional 35 to 40 transfers every week. We recruited additional vehicles specifically for West Cumbria to deal with those transfers alone, because we understood that if we're committing all of our resources to transfers, then the risk would be to the 999 service for people in their own homes. So we admittedly have had an issue with recruitment as well. So for a period of time, not unlike every other ambulance service in the country, we were using private providers. Private providers are becoming very prevalent in the ambulance service. They're snapping at our heels for business. And the NHS has no option but to use them. Every ambulance trust is using them. We are not unique in the Northwest. So we will use providers like St John's Ambulance Service. We will use the Red Cross, but we will also use private providers, but they are qualified paramedics. But what we've done now is we have managed to recruit almost to full capacity, and we've done that with international recruitment. So we have, and it's almost nice to be sitting here today rather than 6 months ago. 6 months ago, I would have said, we have got a terrible vacancy position, and without the support of private providers, we would struggle to deliver. Today, I can say that we have recruited, and we've actually now got in post, an additional 26 emergency medical technicians. They aren't paramedics, but we do have to balance. So we have, for every vehicle that we put out, we have one paramedic on the vehicle and one emergency medical technician, because one of those people will always be driving. So it's a waste of money to have 2 paramedics on every vehicle. But where necessary, where the clinical acuity of the patient is so severe, we will then deploy another paramedic to the scene. In fact, in cases of cardiac arrest, we will have 4 staff on scene. So 2 ambulances will be there. So we've got 24 emergency medical technicians. We've got already in post 11 Polish paramedics. And we have got a further 16 coming in January. The reason we recruit in Poland and Finland is because their academic qualifications are as good or better. Every single Polish paramedic that has joined us has a master's degree. When you referred there to the paediatric transfers in particular and very, very sick children, we don't have any plans to raise the qualification level of our staff, but what we have got in place is a transfer matrix. So where we will consult, so the matrix will be discussed, and essentially it's a document, but it's discussed in conjunction with the clinician caring for the child in hospital and our triaging clinicians that we have on our clinical support hub, and that is based in our emergency control centre. And where it's absolutely appropriate, a doctor will travel or a nurse will travel. So we won't ever send any patient, not just children, with paramedics when they need more care than that. So I hope that answers your question. Okay.
Any more questions? Yeah. We've got one there, and I won't come back to you then. Okay.
Hello, I'm Dr. Kay Harper. I'm a former Penrith GP. I currently work at the Cumberland Infirmary, and I'm a long-standing member of the Penrith Hospital League of Friends. I just wonder if the panel, with its great concern to move patients out of hospital and into the community, which I absolutely support, I think it's best for people to be treated at home if at all possible. I wonder if you have any concerns by the fact that the Care Quality Commission has issued 2 warnings or areas of concern in the last fortnight. One about the closure of elderly care homes and nursing homes throughout the country, which we've certainly seen here in Cumbria. And secondly, just this week, it's issued grave concern about the fact that councils and private bodies are struggling to meet the needs of people who are at home from the point of view of equipment and bathing and all of the other services that they need because of lack of government funding to councils for this purpose. And I just wonder whether that makes you feel uneasy about closing acute hospital beds in the infirmary and also removing a proportion of the community hospital beds too.
Thank you very much for that. Before I pass it to the panel, can I just ask in what role you're asking that question? Is it as an NHS professional or a concerned citizen?
It's both.
Okay, thank you. Who would like to take that then?
Hi. Obviously, there would have to be some concern because in order for the plans that we have for this to work, we need to ensure that, I can't see your eyes, I'm really sorry, hello. We'd have to be sure that there was sufficient capacity and the right skill mix in the community to deal with the patients that we are agreeing would be better cared for in their own homes ideally, or certainly closer to their home if possible. I think the idea of the integrated care communities is that we would be able to look at the resource for that whole community and then see how would we best use that resource to meet the needs of the community. And the reason it's place-based is because different places will have different needs, they will have different population demographics, and they will have a different level of sort of skill mix there already. From an Eden perspective, we're very lucky we have a good skill mix of very committed community staff, and I include adult social care in that, who already do work very closely together, but obviously things can always be improved, and the hope will be that we can actually start to look at the resources we have and match them to the needs of the population and make sure that we actually do start to do, as Stephen says, that 21st century health and care. That really means that we can improve health and well-being and manage people in their own homes, because actually the real bed most people, I would assume, would want to be in would be their own bed.
Thank you. I think my point is it reasonable to close beds before you're sure you've got those resources in the community?
I think that's a tricky one, but if you were to go back to Penrith Hospital when there were 60 beds, we actually, one of the reasons we have such good community resources because we did do that. And we moved that resource out into the community and enabled those people to be cared for at home. I'm not saying it was perfect, and I'm not saying we got all the numbers exactly right, and things could always be improved and will be improved, but it is a tricky one. But we have to do something different because what we're doing now isn't working.
Yeah, I think Stephen just wants to add something.
I just want to add two things, really. One is the financial strategy that backs this up. As you imply, there's a bit of chicken and egg here, isn't there? Because we need to save money in terms of productivity of the scale of the whole hospital to do two things. Partially to get rid of the deficit, but partially to invest in community services. So the plan does argue for quite a big investment in community services to enable the sort of thing we're happening to happen. So it isn't just the hospital has to be smaller to save money. It's actually the hospital has to be smaller to afford the services we need in the community. We've got a good example, though, in Carlisle of how that can work, where the closure of some beds has led to the same resource managing a lot more people in their own homes or in care homes. And the second thing I just wanted to say is this concept of integrated care cuts across everything. We've just done a project in the last 12 months looking at the clinical skills of nurses. And, you know, one of the problems care homes have got is they can't recruit nurses either. And one of the problems that they have is that the nurses end up being quite isolated. And there's revalidation coming for the nurses and so on and so forth. But by thinking about clinical skills training for nurses in care homes alongside district nurses, alongside practice nurses, and we've just scratched the surface of that so far, we can find ways of making it a more attractive system. So it isn't just about money that leads to services not being adequate or care homes wanting to close and so on and so forth. It's a complex mixture. And, you know, the story of the ambulance service is really heartening because as soon as you start talking forwardly about where we're going and strategy, recruitment just seems to get easier. And so there is a connection between the quality of what we do and recruitment as well as just the financial numbers.
Thank you. Right, got a question there, and then I will return to the gentleman at the front.
I've been very impressed with what I've heard so far, but I'm slightly puzzled. The ambulance reply was rather similar to the one that was given in Appleby. What I'm not sure of, is that meeting the current situation when you say that with the 16 coming in January, Is that meeting current demand, or is it meeting the future demand that has been described will come about as soon if these changes are agreed?
Thank you.
It's actually, the reply was similar to what you heard in Appleby, because I was at Appleby. Yeah.
I only read it in the newspaper.
Okay.
I wasn't that happy.
It's to meet future demand. What we did was we had a basic core level of staff that we knew met the activity as it was in 2012, because we remap activity all of the time. We use a program called Optima that tells us, based on historical data, where our periods of activity are going to occur, and we would match resources to that. And we do that for the Northwest. So what we did was we knew how many staff we needed for that, but we also mapped the activity for what we would need in the future, with an additional 20% in growth in activity, and we have recruited to that. So we've got more staff. We will have, in January, we will have more staff in January 2017 than we had, well, last year, this time last year, because we're trying to predict, you know, we work on a 5-year plan. So we're trying to predict for the future what we will do. What I also should have mentioned in my first question, in response to the first question, was that not only do we try and increase our resources to match the activity, we also try and protect the 999 service by initiatives designed to keep people in their own homes, because we know that's the best place for them. So rather than taking every patient that we respond to hospital, we would pathway those people. So we've got pathways set up in North Cumbria that admittedly aren't as comprehensive as other areas, you know, because of where we live. But with them, we try and, you know, so we don't have as many ambulances taking people to hospital. We've got a 35% rate of deflection, which is essentially 35% of all calls that we get, we will not take them to hospital now, which is one of the best in the Northwest, because the staff are so good at it and they have such good relationships with GPs. So I hope that's answered the question. Okay.
Thanks very much. We turn to the gentleman at the front, and then I'll take some more questions from the audience.
I find quite a lot of that, how do you say, not what I've experienced, because my partner's brother was in the Cumberland Infirmary, and he waited 5 weeks, right, to go to Newcastle for an MRI scan. 3 separate occasions, ambulances were cancelled, yeah, and when an ambulance did come to take him to Newcastle, it was a bariatric ambulance, and it was sent from Chester, which is 144 miles away, to Carlisle to take him to Newcastle, and presumably went back to Chester.
Sorry,
I've heard other instances.
Can we get to the question, please, rather?
Yes, I've heard other instances where ambulances have gone from Morecambe to Silloth and got lost on the way to take heart attack patients to the Cumberland Infirmary. And the way you're talking is it's all sweetness and light. So what is going wrong when these instances are coming up regularly? Now, my partner's brother, she rang for an ambulance on Monday night and was told there aren't any. So if, you know, you've got all these extra ambulances and all these extra personnel, all this fantastic service which you think that you're doing, how come it's fallen short?
So just to summarise your question, what you're asking is, what's the root cause?
Why is it failing now when you seem to think that it's working?
Okay, thank you.
Okay, I would dispute that it's failing. You've mentioned a bariatric vehicle. I don't want to ask a personal question, but obviously I would need to understand whether a bariatric vehicle was needed. Yes. Right? You're right, we have bariatric vehicles across the Northwest. But we don't have, no, it's more than 2. We don't have...
You've got a freedom of information request. It says you've got 2 for Cumbria, 2 for Merseyside, and 2 for further down. Okay. Yeah?
Yeah, now we're for the Northwest. So we've got 6.
So the Northwest Ambulance Service has 8 in total.
Yes.
Now, there's about...
Sorry, excuse me, sir. Can you keep to the question?
Just a minute. There's 35% of the population that's obese. Yeah? And you've got that number of ambulances to cater for 35% of the population. I find that's incredible.
Okay. We have got the 8 bariatric vehicles with a plan to get more, but an ambulance, a fully kitted ambulance, costs £150,000. Well, we have to come to money, because everybody has to come to money eventually.
Sorry, excuse me, sir.
So-
I don't want to cut you down, but I draw you to my first comment, which was we treat each other with respect, and I don't feel you're being particularly respectful to colleagues. It's a brilliant question, but let them answer the question, please.
Okay, so the bariatric vehicle, you're absolutely right. If it was being used already in North Cumbria, we would send one from somewhere else, because that has got to be better than not sending one at all. In terms of the 3 times that you referred to that had been cancelled, I don't know why it was cancelled. I can't answer the question. I don't know whether we cancelled it or the hospital cancelled it for another reason. But I can't answer the question because I don't know the details. In terms of sending an ambulance from Morecambe to Silloth that got lost, it wouldn't get lost because we've got satellite navigation on the ambulance. I would find that difficult to understand. But we will always send the nearest available resource. So,
Go and put your postcode, Charlie Alpha 11, 0 X-ray Delta, into your sat-nav and tell me where it finishes. And you know where it finishes? It finishes 2.25 miles from where we live. Yeah? And on 4 occasions, there's been police cars being sent for, and do you know where they've been found? A mile away, looking for it, because the technology simply does not work.
so have you registered that with us? Because you can do that. We've got a point taken initiative where if your property is difficult to reach, you can tell us exactly how to reach it.
You can tell people, but unless you've got local knowledge and specialists, which you've removed from the area, because the calls don't go to call centres in Cumbria, yeah, they don't understand.
No, they do understand.
Cumbria Constabulary don't understand.
Okay, so to sum things up, technology's not working.
No, it isn't working.
So we've got a big issue. Ambulance service, I would suggest we'll take this away, look at that, and we've got the postcode that you just put has given us a record.
The other thing as well is, it seems as like you're sitting here, you've got the cart before the horse, right? You're rather like everywhere else. They quote a website, they quote, you go to this, go to that, use your internet address, yeah? Marvellous. Ministry of Agriculture wants it for sheep to be tagged and cattle, yeah? We've got no broadband, we've got no internet. The only line we've got is the washing line.
Okay.
And the bad news is they can't see our carrying pigeon.
Okay.
Yeah? And the other thing is, I've got a bus pass, but there's no buses.
Okay. Absolutely. All good points, well made.
The point is, you people are sitting there with all the technology, all your big fat salaries, all your company cars and all the rest of it, and the people that live in the great wide world of Cumbria that's sparsely populated have to accept second best.
Okay. Thank
Can
you
you give me that postcode again?
Sir, I really appreciate it. And I appreciate your honesty. It's very important to make. Thank you.
Would you
Postcode again, please, sir.
Could you give me the postcode again, please?
Because what?
The postcode.
The postcode.
Charlie Alpha 11, 0 X-ray Delta. And some of them don't even understand the phonetic alphabet when you ring them up.
Okay.
Okay, I think my last point would be I live and work in rural Cumbria, so it's as important to me as it is to you.
Right, I'll look at your staff.
Okay. Thank you, sir. Thank you for that honest. Any other questions? We've got a gentleman at the back and a lady there. So we'll take the gentleman first because you caught my eye first, and then we'll go to that lady there.
Thank you for that. I'm from the Herald, and I had 2 elements to my question, really. One is, what's wrong with beds at Penrith Hospital, as they are? Can somebody tell me, actually, what's wrong with them? Why take them away? And in terms of integrated care communities, how do you treat people in the home when we're under 6 foot of water?
Okay. 2 points. Who would like to take the first point about the beds?
It's okay, I'll leave the 6 foot of water to somebody else, and I'll take the first question. Thank you. It's difficult. Everything can be improved. So presently, if you were to look, there are some people in Penrith Hospital now who ought to be at home and can be at home and are fit enough to be at home, but for a variety of reasons they aren't able to get home. And the issue with that is that the evidence is overwhelming that lying or being in a hospital, whether that's a community hospital or an acute hospital, is not necessarily the healthiest place to be. It is if you have an acute emergency and you need acute medical treatment, absolutely you need to be there. But actually once the acute medical treatment has finished and you are needing to recuperate, reablement and rehab, that actually is best done in your own home with the right people. So yes, you need your therapists, you need your community nurses, you'll need potentially the help from the GP and still the specialist. But actually that should be in your own home. So at the moment we have people in hospital beds that shouldn't be there, if I'm honest. And if we look at the numbers of people who are at present where they shouldn't be, in the wrong bed, I suppose, that's actually a proportion that would allow us to remove some of those beds and therefore the staffing of those beds, the resource that goes with those beds, and move that into people's homes. And therefore, as Stephen said, the example of Riva House in Carlisle means that we are able to care for more people in the right place with the right level of care and support. And that makes, I'm not big on the finances, it does make financial sense, but actually it makes sense for people, their relatives and carers, because it's much easier for you to visit somebody in their own home or be with them in their own home than it is to be travelling up to Carlisle and even Penrith Hospital. There are people travelling a long way to come there and see their loved ones. The 6 feet of water I'm going to look for some support on. Anybody want to go on, Stephen?
I presume you got tongue slightly in cheek, because you'll know as well as I do that bad precedent makes bad law. We are not suggesting for a second that we would build hospitals and beds just in case a flood meant that people couldn't be looked after in their own homes. But I take your point. I take your point that, you know, with our partners in the local authority, we have to have contingency plans for when people aren't safe in their own homes. And that, you know, we take the safeguarding of adults under all circumstances, be it, you know, flooding or anything else, very, very seriously. And, you know, it isn't just your own home or nothing. It's about how we plan together for all kinds of contingencies, including the possibility of future floods, obviously. But as Rachel was saying, and I was reading some research recently, and you'll remember this one after I've told you. If you're over 80 and you spend extra days in hospital that you don't need, every day you're in hospital, your confusion rises and your muscles waste away with the equivalent of about a year's aging. So if you go into hospital age 80, and spend 10 days longer than you needed to lying in a hospital bed, you come out like a 90-year-old, having lost muscle, lost your orientation. And, you know, we're smiling, but this is serious. And you'll have seen it happen to friends and relatives. They waste away in beds, which when they were coping fine, knocking around their own homes. This is a serious issue, not just of how do we manage our resources best, and the important chicken and egg thing we were talking about before, which is very real. It's very, very important that as much as possible, whilst obviously with due regard to safeguarding, we do look after people where they want to be looked after, which is usually in their own homes.
Can I just saying that you don't get those 10 years back? And so if you've lost those 10 years, it doesn't come back.
Thanks very much. Lady at the back there. Yeah.
Do I really need to use that? I work for the older adults team, and I really just wanted, I suppose, I have got one question, but if you'll indulge me a moment, for the sake of the gentleman perhaps on the front row there, I find it immensely rewarding to work as part of a really, you know, close team in the community. And I really do believe that that is the answer. I hear that it's difficult because it is chicken and egg, and I guess my question is about the district nurses and what we're doing to support them to, you know, continue to make the changes that they need to make so that they aren't overwhelmed in the process. So that's my question. But yeah, for the gentleman on the front, I do hear what you say about rural, you know, the rurality of our area, and I can just say from my own point of view that you can work in a really integrated, very close sort of way with the people who do have the knowledge, you know, in the communities, you know, who have that knowledge that you were talking about, that you touched on. And it's immensely rewarding. And Andrew's point about care home staff, I've also worked in care homes, and nurses do feel really, really isolated. And if we can work together in really strong integrated teams, we can bring up the level of training. And so we're all, you know, singing from the same hymn sheet, and we've all got sort of, you know, sort of similar quality of care.
Okay, so the question is...
It is, what are we doing are we doing enough to support sort of especially district nurses, for example, who are going to have to be a big part of that?
Support for district nurses.
I'll have a stab at that, but I might hand over to my nursing colleague over here. I think the whole thing about teamwork is really, really important, not just in a district nursing team, but in any team. And you'll see in any NHS setting now that importance of what we call the multidisciplinary team. So the doctor, the nurse, the therapist, even the administrator can play a key role in that. Are we doing enough to support district nursing teams? No, probably not at the moment. But it is all the things that we've got planned around. So things like enablement around IT equipment, your ability to get prescriptions quickly, your ability to have things at your fingertips when you need them, so you're not making those kind of wasted journeys, wasted calls. Certainly some work I've been involved in the past where there was a lot of complaints from district nurses that they were passing each other on the road because they were their diaries hadn't been properly coordinated. So yes, I think there are a lot more things that we can do that aren't necessarily expensive or clinical. It's just some of the fundamentals enabling you to get that right. And I think that's where the development of the integrated care community, where you're able to have those discussions with all of the people who are involved in the care of that patient at any given time, and you're not waiting for a meeting or a phone call. That, for me, is the basis that will really start to underpin the excellent team working that we know already exists, but will enable us to make it better.
The lady at the front there.
It's the back office that wants training using the technology that already exists to do it. Because we get district nurses that come to Mother Hall, to John, twice a week. We get them from all Sillett, Kenton, all over the county, right? Sometimes they say to me,
Excuse me, sir.
It's far better if we had a helicopter. And I mean, you go to the Cumberland Infirmary.
Excuse me, sir. Could we take this? Yeah. Can we finish this out? I'm sure colleagues would be absolutely delighted to have this conversation.
Yeah, but there's a lot of other people in here wants to know what's going on.
Yeah. I actually wanted to ask the lady next to you who made it.
I'm happy to listen to
When
you
you
as well.
when you go to the Cumberland Infirmary and you go to A&E, right, and you want an X-ray and an ultrasound, how do they find out? Go on, how do they find out whether there's a space for you? The nurse walks to the X-ray department or the ultrasound with your records or a piece of paper to find out if there's a slot. There's no direct communication from the computer in A&E to the X-ray department to find out if there is a slot.
Okay.
And there's slots being wasted and underutilised, and the full capacity of that department is not being used.
So if I could summarise what you're saying into a question, is how can the technology be used more effectively to ensure that people get their needs met? So I'll ask the panel to comment on that, if I may.
Well, I can give you a layperson's view of that. But as part of the work that we're doing around healthcare for the future, the success regime, we have a a work stream on what we're calling it infrastructure, so IT technology. And we know we have these issues. We know we have different sets of patient records for historical reasons. The interfaces are getting better, but they certainly could be improved. And you're absolutely right. It isn't necessarily about the administrative person. It's about the technology that supports them, enables them to press that button on that screen, which gives them that answer for another system. So all of that is part of the work that we are planning to do, which supports not only the district nursing team, but enables hospitals and GPs and the ambulance service, etc., to talk to each other.
That's why there's other things, and that's why when you go to the Cumberland Infirmary, they're still walking around with patient records in little trolleys.
Yeah. Yeah. And that happens across the NHS quite a lot, unfortunately.
There's NHS Net, which is a secure system to reach GPs, and they're still posting letters and faxing them in Cumbria.
Well, it isn't just in Cumbria either. I know that we do have some broadband problems, but if you look at other areas of the UK and also abroad, as Stephen was referring to earlier, who have real remote and rural problems, I'm talking about hundreds of miles between yourself and your GP. The technology does exist. We do need to improve that. We know that. So these are some of the things that we do have in our plans about the developing services going forward.
Okay, thank you very much for your comments, very valuable. I got a gentleman there, lady, and then I'll take a lady there. So let's go to this gentleman here first.
Thanks. Hi, good afternoon, panel. Neil Hughes, Chair of Cumbria Health Scrutiny Committee. But it poses this question. I'm the lay rep on the Eden locality of the Cumbria CCG. So it's a question for Rachel as Chair of Eden locality, the one we have discussed before, but Eden's going to be a very large integrated care community in terms of geography and the breadth of services it'll have to address. But there are already arrangements being put in place in self-contained communities such as Alston, particularly with their own individual needs, that would suggest there is scope for subdividing the ICC into more local arrangements. And of course, this could happen in other parts of Eden as well, as you're aware, but also out with Eden in places such as Brampton and Wigton. Would you agree that's a possibility? And is there some work taking place to make sure that happens so that people can be more sure that, for example, community mental health workers, district nurses and so on, OTs, will be available in their local part of the district?
Yeah, I think the reason when it talks about the sort of 20,000 to 70,000 is that you need the numbers of people to be looking after to have enough need to have the right level of, I suppose, clinical input that you would need, so the therapists that you would need and the nursing that you would need, even the adult social care and the care that you would need, to be big enough to cope if somebody is off ill or if people have to go on holiday. And obviously when you make something very, very small, you're normally just relying on Margaret, and Margaret knows everything that goes on, but if Margaret happens to be on holiday or away, then everything falls apart. So the reason we're trying to do it in that sort of scale is that you need enough people and resources and the skill mix to be able to provide for the needs of that community. Absolutely, I have no problem if each village works out its own, I'm trying to think about this its own sort of dementia champion in each village that runs things to help people with dementia in their community. I think that would be fantastic and ideal, and that's what we're looking for. But it may be that 3 villages need to clump together to get enough people to then say, well, actually, we'd quite like somebody to visit once a week to do some health promotion or come and do some singing for the brain. It's that bit. So I don't think just because we've said it's Eden that we are restricting it to everything has to be that big. Okay. But we have to have a footprint. That means there's enough resource coming to those people to actually provide for their needs. I do
understand that. But in cases where a subdivided part of the area makes its own arrangements, such as in Alston or potentially the Upper Eden Valley, will the CCG honour that kind of ambition?
I'm not sure it's up to the CCG to honour anything from that perspective.
It's up to the leadership of the ICC in this case.
And the leadership of the ICC is the community itself. So if the community itself comes up with a plan that works for them, driven by them, and the resources are available, and we can get the skill mix together, absolutely.
Okay, great, thanks.
I'm going to just change the order. Take to the lady, and then I'll come back to you. Thank you.
Is it on? Yeah. If the integrated care community is going to work, it seems that there needs to be a really strong partnership with adult social care and the voluntary and community sectors. And it strikes me that both those sectors are very under-resourced and overstretched as it is at the moment. So I'm quite concerned about how they're going to be asked to join in with this. Is there any indication that there will be additional funding or resources for adult social care or for the voluntary and community sectors?
Hi, I think that's a really good question, and you've picked out two areas that are in particular stretched, but I think the conversation here this afternoon, it's a general issue for health and care services in the broadest sense. The plan that's been put forward as part of the clinical strategy that Stephen was outlining earlier makes it clear that in order to be able to develop integrated care communities, we need to increase the amount of financial resource that's available to them. So it's costed within the plan that there will be quite a considerable level of investment into individual care communities, and it's up for those communities to decide, in much the way that Rachel was describing in answer to Neil's question before. It will be up to those communities to decide where they best need to spend their money. So if they feel that they would be better spent in the two areas that you've just described, then they will have the freedom to do that. So that's part of the answer to your question. I think the broader answer, it comes back to, yes, those two areas are very, in particular, colleagues in adult social care, I know, are very thinly stretched. I think the other part of the answer is about creating the kind of flexibility that you've been hearing about in the answer to several other people's questions, and about how people can work differently to provide individuals care. And we know that from the examples of where in some areas they're starting to test these ideas out now, that we can make much more use and help people to work much more effectively if we manage to break down some of the barriers between adult social care and perhaps district nursing, general practice and the other areas that are included.
Can I just say something really? What I was going to say is I think what you're trying to say is a lot of this actually looks at prevention being better than cure. And actually, I think what we need to be looking at is much more about how do we prevent people from falling in the first place so they then don't end up needing the ambulance that then has to take them to Carlisle because they've broken their hip. And actually, if we'd stepped back a little and put more provision and more support into keeping that person's muscle age nearer to 75 than 90, therefore they will be less likely to fall. That I hope, and I am sure, given the evidence that we have, is where the integrated care communities will start to look to be putting more of their resource, because actually that will be the thing that will deliver the improvement in health and well-being. It's not just focusing very much on the sort of acute clinical end of it, because then we've kind of missed the boat some of the time. Oh, absolutely not. No. Yeah, absolutely not. Yeah, and I think children's resilience is one of my absolute sort of things that I believe in, and I think if we can't put the right level of support into schools and families to create resilient children who will grow up in our communities to become resilient adults, then we're going to be really stuck. And that's why it's called an integrated care community. It's about the community, and as you say, that's everybody in the community. And we do get a little bit skewed about the elderly. I'm sorry, that's another passion of mine as well. So they kind of go both ends, I promise.
So just for the benefit of the record, because I'm conscious we didn't get the mic to you in time, your statement was saying that we need to be balanced for the needs of children as well as the elderly. And yeah, work together.
The elderly support children.
Yeah.
We're supposed to be working together as a family, if you like.
Yeah, so it's thank you very much. I just wanted to make sure we picked that point up on the record. So we've got a follow-on question here around that. I haven't lost all this lady here.
Could I just ask how much patient participation you've had in your groups? And would it have been helpful while you're having your meetings that there was some patient participation there? They might have been able to help you with some of your problems. Thank you.
Thank you. Thank you very much.
I'll start. We did indeed involve lots of stakeholders, including patients. We're all patients ourselves as well. Well, you're all patients, aren't you, some of the time? You've all... is there anybody in the room who hasn't either seen their GP or been to hospital with either themselves or a member of their family in the last 12 months? So we all are. Every single one of us. Yeah, but in terms of the development of the plans, the answer is yes, we did. And we have an active programme listening to patient participation groups in practices, not all of them, but some of them. The working groups that developed the plans had various stakeholders, including local authority, but patient groups as well. We're continuing to do that now. And the real challenge comes with the implementation. And then I'm totally with you that the implementation of any of our ideas really requires the voice of the patient, the voice of the community together. Just to add to the point that was made earlier about, you know, the idea that our strategy is about communities working together, and it's the NHS and it's social care and it's the schools and so on. Yes, and it's us who lives there too. And you know, we need to form alliances to support the better production of these care communities.
This gentleman who wants to add on to it. I haven't lost the question there. I will.
I must admit, I've been quite impressed with the answers that have been given. And I think it would be helpful if some of what you were saying could be put out in a more general paper. Let me just give you one illustration. You've made the comment that you want to close beds in Penrith because that would make a certain amount of money available into the community area. I think if you could put numbers to that, you might get greater support for the changes that you are suggesting. In the paper at the moment, you talk about the way you want to make the changes, but you're not. I don't think you're specific enough for saying, look, if we save 6 beds in Penrith, this gives us this amount of money, which we could use to do this in the community.
I think that's a really good idea.
Yeah,
and I think we have, and I think we have sort of tried to do it, but it's not coming across in the way that we can communicate it effectively, and I think that's the issue. Because I think then people can understand if you were to go into a shop to buy something and somebody were to give you 2 options, you'd understand what you'd get for that option and what you get for that option, and then that would be an opportunity to decide. And I think that shared decision making, which we certainly as a GP is how I would like to think we approach decisions about treatment or care, is how we should be doing this consultation. It's how we should be co-creating the integrated care communities, because actually we're all capable of weighing up pros and cons and making decisions, or most of us are, and we should be using the collective brain of our community to come up with some really good ideas and really good ways forward, and I look forward to doing that.
Yeah, I was just going, can I just agree, but make the point, there is a lot more information on the website, both in terms of fact figures. Yes, and including. Yeah, the document is big enough, isn't it? And including a whole kind of business case that supports the modelling and the movement of money and all that sort of thing. And if anybody's interested in that but doesn't have internet access, if you contact us, we can get a paper version of that stuff for you to browse through. I would say that we do live in a society driven by the 24-hour news media who like to reduce everything to a soundbite, don't they? And this is actually more complex than a soundbite. In fact, it's very complex because it goes all the way back to, you know, issues of health and expectation. You know, there's exercise, smoking, diet. There's all sorts of things that communities have to tackle to make the best use of the resources available to us when it comes to care. So the financial arguments, the health arguments, the science arguments, the service configuration arguments, we'd be the first to admit they're dead complicated. And it's hard, but the more information you ask for, the better we are enabled to say, well, let's share more, and let's have this discussion. And
feel free to do that, though. Some people just don't feel like doing that, and actually are frightened of doing that.
Yeah, well, that's their choice too. And we're trying. We're obviously trying.
To communicate their needs.
Yeah.
And their rights and their choices, and that's what the NHS is all about.
Yeah.
It's about choice and good service, and but some people just haven't got the ability, or have got a fear of speaking out, and perhaps the processes that are there at the moment just aren't working and need to be reviewed.
I think we're on the same side, aren't we? Because the whole of my introduction was about the fact it's not working at the moment.
Yeah. So perhaps you might want to have a conversation with the panel afterwards.
How would you say the reduction in funding by the government on...
Sorry, can't hear you.
Yeah, can you speak to the microphone, please?
How do you say the reduction in funding by the government on rural pharmacies impinging on patient choice? Because not everywhere has pharmacies like they do in London, where there's one within 2 or 3 minutes walk. You know, you've got one in Espatria, one in Wigton, a doctor's pharmacy in Colbeck. How's the patients going to get the prescriptions if there's no pharmacies, if they've failed through rural funding cuts?
You're absolutely right. There are real issues about how funding choices are made. One thing I would say is there's more pharmacies than there ever used to be, and the way we're getting our prescriptions is changing a lot. Lots of people are getting them delivered now. People are getting them via the internet. People get them via their doctors. One thing's for sure is no community is going to have a plan where you can't get your prescriptions.
The other point I was going to say was to the lady from the ambulance service. When I was reading the paperwork, it said that there was going to be 200 extra journeys from Hensingham with maternity patients to Carlisle. It proposed a journey time of between 45 and 48 minutes. Presumably, when you're going to buy these ambulances, you'll be getting them from Ferrari or McLaren, because it means a 60 mile an hour plus average speed.
So what's the question?
How do you propose to get from, say, Egremont to Carlisle with a maternity case in an ambulance in 45 minutes?
Well, the reality is we won't.
Well, why put it in the document when it's not true?
I didn't put it in the document.
Well, it's in. Surely you'll
that
have
would
read
be
it
an
and
average
vetted it.
time.
Yeah.
That would be an average time.
Okay.
And on blue lights, it's probably possible, but on blue light, without blue
Well,
lights, it
yeah,
isn't.
my friend's Malcolm Wilson. I'm sure he would be able to modify an ambulance for you to get it there.
Okay, Tick. The point's made and noted that there's some concerns about the average times quoted in it for transfer. That's your point.
Highly concerned.
Yes, okay, highly concerned. Noted for the record, thank you. Sorry, there's a lady here who wants to make a comment, and I haven't forgotten.
Thank you. My name is Linda Mitchell. I'm the Secretary for Penrith and Eden Community Hospital League of Friends. I would actually like to support some work that's been done with the ambulance service through League of Friends, which has stopped some admissions to the acute hospital. We were asked to purchase a razor chair for patients who fall maybe in their own home. An occupational therapist goes out with an ambulance, either technician or paramedic, goes to the person's home, is able to lift this patient up, and whilst doing that, hopefully have been able to save a lot of journeys through to the infirmary. I hear that they've stopped 60 admissions to the infirmary in the first 37 days of this pilot. And not my question really, but my comment is that by working, we are a community-based charity, we are able to raise money which is being used and is being used very, very successfully. This is all part of the community hospital and all the community services that run from Penrith Hospital. A wonderful hospital, I think. But the staff came to us with their idea of this razor chair, and it cost us £3,000. £3,000 to save 60 admissions to the hospital just by thinking outside the box. And that is what I see as integrated care.
Yeah.
I think
perhaps Linda would like to take that first.
Number one, thank you, because I'm sure at least one of those people will have been one of my patients, so I'm saying thank you on their behalf. Anybody who wants to raise money for more razor chairs across Cumbria, I'm sure that will be welcome as well, because that's been a fantastic piece of work, and the hope is that the idea behind doing that is that other ICCs, and in fact potentially more within Eden, will look at that, be able to show that that's something that works and helps. It helps the ambulance as well, because those journeys were therefore less time than they would have been had they had to transfer up to Carlisle. So that ambulance is back on the road again, along the 999 front, hopefully heading towards the child that needs to be transferred. So it works for everybody. And I think actually Eden is a really good place where we've done lots of things like that. What we need to do is learn from them and do more of them, but also share them across the whole of North East and West Cumbria, because I think in other places things don't work quite like that. And there are other things that we can learn from other places in Cumbria where they do things that would be brilliant here. So it's that learning and sharing across that's really important. I think
learning, and I'll bring Caroline after that.
Yeah, I just wanted to say thank you as well, and to talk about another example of where we've worked as a community and with the Joint League of Friends. As you know, as Stephen highlighted earlier, we do have recruitment issues here, and we've had particular recruitment problems in our community hospitals. And through some work that we've had supported through the Joint League of Friends, we've been able to send people to national recruitment fairs for nurses. We've got lots of interest because people have seen that the community are there trying to encourage people to come and live and work here, and we're hoping to have some really positive results from a recruitment perspective there. So even though it was funded and supported by the Joint League of Friends for Community Hospitals, we've worked together as NHS trusts, and we've got people who are going to come and be interviewed in Carlisle in the next few weeks for jobs right across Cumbria. So there's some fantastic examples of how the community working together can really support what it is that we're trying to do. Absolutely, absolutely. Well, there's lot. I mean, if I had the answer, I wouldn't be sitting here. I'd be selling books to millions of people. But actually, there are some very, very simple things around keeping good staff. One is listening to them. Two is making sure that they have all the equipment and the support, etc., that they need. Three, I could go on around training, that they are treated with respect. So again, all of the trusts here and all of the organisations have looked at their values and the way that we treat each other and individuals, because we have some amazing people that come to work for us, people who will work long hours, long over what it is that they're requested to do, because they fundamentally believe in what they're doing for patients. And as organisations, we need to make sure that we are supporting them. We lose too many good staff. So our own internal processes need to be better, and our behaviours need to be better as well. And that's just not senior managers to staff, that's staff to each other.
Okay, thank you. Just for the record, the follow-up question to that Lynn just responded to was, how do we keep hold of good staff? So Carol, you've got some comment.
On the point that you raised with the pilot that took place at Penrith, you're right, it was very successful, anecdotally very successful. We're just evaluating the figures at the moment, but I think the thing to say as well is the staff absolutely loved it. I think they felt part of the community in a way that maybe they don't when they're just taking patients backwards and forwards to Carlisle. While we're evaluating that pilot, we're starting another one in Egremont, to see if we get similar results there. But when we talk about 21st century healthcare, this is what we're talking about, and moving away from the way we've always done it to the way we're going to do it. So thank you very much for enabling us to be part of that.
Surely this is about staff morale as well.
Sorry,
yes.
Can you repeat the question?
Surely this is about staff morale as well. If staff have the equipment and are taking part in good pilot schemes, as you are doing, and with the support of us from the League of Friends of Penrith Hospital, that creates good feeling as well for the staff. They feel they're achieving something with some simple piece of equipment. And this is what it's all about.
It absolutely does.
The community, the League of Friends, and everything else. If we don't get the money from the community, we can't support your pilot schemes to you, to the community nurses team, and anyone else working in the hospital who asks for help.
Absolutely. I completely agree with you on that. That's not to say we don't have equipment, because we have lots of it. But I do absolutely agree. And staff morale applies to us all. Because sometimes when we talk about staff, we don't talk about managers. And we feel the same in that we all want to be able to come to work and feel like we've made a difference, especially in the NHS, because a lot of the time the NHS is as good as the people in it, because it's the people that are holding it together a lot of the time, and we all need to carry on believing, if you like. It sounds a bit hippie-ish, but you know, we do. We need, you know, we need to be able to believe in it tomorrow and next week. No, I can.
Yeah, sorry. Could you mind repeating the question, please? I didn't hear at the back.
It's all about health, and it's also about staff health. And how do staff get poorly? How do they get to that stage of illness?
I can answer for the ambulance service.
Well, the NHS.
Well, I can't really answer for the entire NHS, but I can answer for the ambulance service because that's my area. Our staff do have a lot of muscular injuries because we still have to lift people, and we have to do difficult lifts and carry people downstairs because we're not in a contained environment. So we do have a lot of that. We do have a lot of mental health issues, and we probably haven't been as good as we could have been on that, but we're getting better. And we've introduced a thing called TRIM across the ambulance service, which is trauma management, because what we find is exposure to traumatic sites has a cumulative effect. And staff might think they're all right after they've been to a series of things that most people will never go to. But they'll get to a point where they just tip. And we recognise that, so we have...
do you recognise that?
We absolutely recognise that. We recognise that. We recognise now that it has the cumulative effect. What we do, we have a thing called Mind as well, Blue Light Mind. So we've got ambassadors, if you like, that are staff.
Right.
And they are there purely to promote mental health, well-being, and how to manage your own mental health, as
So
well
where
as...
does that staff member go in the initial stages when they're feeling not well?
They will
Or they're
go
just
to...
feeling...
They will either go to one of our trim assessors, and they are also staff. So we've got a cohort of staff.
So you don't go to your GP anymore?
Well, obviously, you would still go to your GP if you... Yes.
Yeah, I'm just wondering how it all ties together.
Well, what it would... Initially, in the first stages, it could just be that they're still at work. They're not at work. They're still at work. Right. They're recognising they're not feeling great. Sometimes we can see it in them. And also, common sense tells you when you know they've been to an incident, and that's what our managers are for, it's going to have that effect. It is. Without knowing whether it has, potentially it could. So we will start that process as well of saying, are you okay? We want to refer you. We want you to see a trim assessor.
Is that like a risk assessment?
Yeah.
Health and safety risk assessment?
Yes.
Right.
Okay, so that's answered your question. Anyone else wanted to add into that, please?
Well, just speaking from the Partnership Trust perspective, and I think probably from the broader NHS perspective, we talked before about values and behaviours, so we can put interventions in place like stress audits. We have other mechanisms by which we spend time with staff, try and understand what's going on. We look at sickness absence rates, we look at other interventions that try and tackle things like that. But actually, sometimes it's just having the time to notice that your colleague isn't looking too good, isn't too bright, and feeling able to then say, is everything all right? Also, it's a manager's responsibility as part of their busy day to pick up on the staff. You know, she doesn't crack the joke that she usually does. He's really quiet. It's about having time for each other as well. Now, the NHS has a really high incidence rate of mental health and musculoskeletal issues. It's part of the job. So do lots of other industries, and I think organisations have got wise to the fact that as responsible employers, there are things that they can and should be doing that we get measured on as organisations to make sure that we are trying to support staff with these kind of sickness issues.
Staff feel able to do that, to actually access those interventions, if you like, without the risk and the fear. There's obviously a fear there that,
Well, I think you
not
only
always
need
treated
to
as
look
well
at
as it could be.
things like the the numbers of people who do take advantage of these things. When you look at feedback from staff survey where staff are asked, do you feel able to raise concerns, to raise issues? Yes, they do.
Yeah,
Yes,
sorry,
they
with
do.
the permission of the audience, I think I'd like to ask you if we could...
It's a cost issue.
Yeah,
you know, it's
yeah.
a cost,
Can we
and
take
the massive amount
yeah?
is cost?
Can we
for
take the
NHS.
conversation towards the end?
Can I just answer the
one-
cost perspective there? Because you're absolutely right. Sickness absence is a massive cost. But if you look at the NHS as an organisation, 75% of its cost is related to staff. So even if you only looked at that from a cold, hard cash perspective, if you don't fundamentally look after where all your money is going, then you are not a responsible employer. And we have recognised that. Now, we can't cure it overnight. But lots of the changes that we're proposing making to services will do things like lessen the amount of time that people spend on their own responsible for a whole hospital at night. People who feel they have to come in when they're not well because they can't let their colleagues down because we can't recruit enough people to come and work in these services. So as Stephen said in the introduction, we do have workforce issues, and a lot of the changes that we are trying to make are to support those changes which will have a positive impact on staff.
It's not just a cost on you, though. It's not just a cost on the employer or the NHS. It's actually got a knock-on effect of the cost on family lives.
Absolutely,
and
yeah.
on-
I don't think anyone's disagreeing with me. I'm sorry, I don't want to seem like I'm shutting you down. I know. The last thing I want to do, I'm very conscious that a lot of other people in the room have got things to say. Can I just ask two very quick things of you? One, that you raise your hand when you've got a question, because I know there's some people who have followed that protocol who are waiting very patiently and have got things to say. And would you wait until the microphone gets to you before you start speaking? Because the people at the back actually are having real difficulty hearing, and it's kind of not fair. And the other thing I'll say is that if you don't get recorded, it doesn't get picked up in the consultation. So, and I'm really keen that everything that you have to say is heard today. So there's the lady in the fleece there who's been waiting very patiently.
Thank you. The risk of sounding a complete obsessive about hospital beds, which I assure you I'm not really, I just wanted to say that I'm beginning to feel that hospital beds are really rather like badgers. You know, they've been successfully culled over the last 40 years, and we've got 40% fewer now than we had back in the 1980s. They're accused of causing illness in people and making them degenerate. But apart from that, they are actually well used. And it was really based on the comment from the gentleman from the Herald about the floods. We do have to be careful with our hospital beds, I think, that we don't reduce them to such a point that if we do have a crisis, a flu epidemic or whatever, that we're not able to cope. And we know from looking at the statistics for the community hospital beds that we've got well over 90% occupancy, nearly 100% in some cases, which means that there's never, you know, the beds are just sort of hotbedded in and out, and there's no leeway there for any unexpected events. So please, could I just plea that when you're thinking about hospital beds, you don't just continue down the line of cutting and cutting and cutting until it causes detrimental problems.
Is that a comment, and you'd like a response from the...
Well, yes, a comment would be nice, but not sure.
So it's a response from the panel, please.
And I suppose we're back to the conversation that we had before, that it's caring for people in the right place and making sure they're getting the appropriate level of care that they require in an appropriate place. So actually we need the beds that we need for the community, and actually we will always need some hospital beds. We're not talking about having no hospital beds at all, but actually as a community we can work that out together as we improve the offer for people in their own homes, as we do the proactive prevention work that means people are ageing well and needing hopefully less acute and medical assistance because they're managing independently at home. And I actually talk about children and families in that as well, because actually if we are managing our mental health well, if we are resilient, if we are looking at the prevention with smoking and diet and exercise and all the things that we know help.
Sorry, can you wait?
So I think it is just looking at that. If we get all of those things lined up, then actually we'll know what the reality is of what we really need for the acute need that is clinical, that requires a hospital bed. So we're not closing them all by any means, but we want to use them appropriately for the right people at the right time.
Yeah, you're absolutely right on that, and I would support you 100%. All I would say is that obviously with the preventative issues, that's not going to come on stream immediately, is it? It's just we're doing great guns with stopping smoking and improving heart disease, but that's taken 30 years. So you can't suddenly close all the beds on the assumption that public health issues are going to respond immediately.
And I think I would completely agree with you on that as well. And I think this is a graded scaling of things so that we've got the right things in place to keep people safe.
Thank you very much. This gentleman at the front here.
Chris Mitchell, League of Friends. My question's in two parts, really. First one's about the consultation process itself. Two things on that. It seems unfortunate that we've got the current health consultation going on, and the County Council simultaneously launched one on residential care homes. Sounds again like lack of coordination between adult social care and the NHS. So I think that's likely to be confusing for the public as to which consultation are they taking place on. The second thing's about availability. These are very glossy brochures, and there's already feedback that the public are looking at them and saying, those are far too expensive, I can't take one away. It's typical Cumbrian value for money. They don't want to take them away from reception at the hospital or from the library because they just think that's far too expensive for me to have all one to myself. There are issues about replenishment, and I'd channel that to Freshwater, that there are hospitals that have had their initial stock but they're running out, and I'd ask them to concentrate on replenishment on that. So that's common. The second part, which will need an answer, is about the actual structure of the clinical commissioning group. We know that from April next year, the clinical commissioning group that covers all of Cumbria is being split north and south. There are also suggestions that that's not the end, that north won't be sufficient to survive on its own and may get joined up with northeast. The point I want to make is, with all the work you've done on the success regime, is anything in the changes to clinical commissioning groups going to affect any of the planning that you've put in?
So 2 questions. First off, about the consultation, and the second one about... So who would like to take the question about the consultation first?
Well, I was going to say, if I do the second one first, then
Okay.
I can work out who wants to take the other one and gets me out of the other one, possibly. I don't know. You're right, the CCG is proposing having what's technically known as a boundary change. We will still remain as Cumbria CCG, but the GP practices that are in the south of the county, that's those that are in Furness and those that are in South Lakeland, will actually be moving to form a different CCG with colleagues in North Lancs. So the CCG from the 1st of April next year, it is proposed, will cover the districts of Allerdale, Copeland, Carlisle and Eden. That will still make us one of the largest CCGs in the country. At the moment, we're one of the top 4 or 5 CCGs in the country in terms of size, and size is measured in terms of the population that you serve. And we'll still be serving over 300,000 people. And there's no suggestion that I'm aware of, or that any of my colleagues are aware of, that as a CCG we won't still be big enough to be able to look after the affairs of the care of the people of North Cumbria without having to join in the way you've just suggested. Where I think it might get confusing is there are also quite a lot of different levels of planning that take place in the NHS. And in terms of the planning that we do with our overarching body, which is NHS England, we're in a group with North Cumbria and the North East, and we do quite a lot of joint planning together, but that doesn't mean your CCG changes, and that's where I think the difference might be in the two. Are you doing the consultation?
Well, if you like, yeah. If you'll excuse the vernacular language, we're damned if we do and we're damned if we don't. We've had many more complaints about inaccessibility of the document than we have of spending too much money on it. your comments about making sure that where in libraries, in GP surgeries and so on, that they're replenished are being taken to heart. So there is a process for making sure we do that. And I think, just to remind people, they don't have to take one away because you can look at it online. But of course, if you're not online, you want to have a paper one. Similarly, it's often easier to fill the actual response form on the back in writing on paper than it is for people to use the internet. So we're trying to find the middle way and obviously not spend money unnecessarily, but make sure that the document is as accessible as possible. But your comments will be taken on by the team. As for the coordination with the County Council, yeah, well, we keep trying. We try and make sure we're as coordinated as possible. I mean, there's actually some mental health consultation to do. There's a consultation going on about maternity in Kendal at the moment. We're consulting with the staff of the CCG about the very issue you just talked about. What's really important is we make sure that we use different kinds of forums. Not everybody likes public meetings, for example, but we have public meetings, we have stakeholder meetings, we engage with Health Watch to do other kinds of engagement. We're making sure that there's staff engagement, that there's processes happening by email, people can write in, and so on and so forth. So that, whilst you're right, we need to make sure we're not confusing people about what we're consulting on and what we're not. We also need to make sure that we're being clear what questions are being asked and how people can respond. So any suggestions from anybody on how we could improve that process are very welcome. Thank you very much.
There's a lady there, waiting patiently.
Like many of the people in this room, I am also concerned about the cutting of 29 beds across the county in the community hospitals. We're often being told that we're an ageing population, and yes, it would be nice to be looked after in your own home, but there are periods when you're in your own home and you're on your own and you're very frightened. That has really been taken care of, I think. But another thing I would like to bring up, I read in the paper at the weekend, looking at preventive care, that there is a talk of cutting health visitors and cutting out school nurses. Any comments?
I think that comes back to that stuff in the paper is often a little bit of a bite-sized chunk that doesn't necessarily reflect the complexity of what's being proposed. And I think there are some proposals to say that we similarly looking at elderly care and being more integrated, that there may be better ways of providing for child health from 0 to 19, and that looking at how we might do that in the most efficient way, because yes, we have only got so much money, but also in a better way to make sure we get the best outcomes possible for our young people. And I think that's what that refers to. And that really is coming under the council more so than us at this point in time. So I would have to defer to them, and they're not here to answer that bit.
Chicken out.
Yeah, I've chickened out, okay. On tape as well.
Lady here.
Can I just add something? Because I really believe passionately about this. I tried to point out that there are some things we're going to do absolutely because of the money, but many things we're going to do because it's the right thing to do. And if we were sitting on a pot of gold and we had a different government that had allocated different resources to social care and the NHS and so on, speaking both as a doctor, as an increasingly ageing person myself, retired once and had to come back, I'm the main carer from my mum, I would not be advocating more beds. I'd be advocating enough beds, as we've all said, for at the right time when you need it and you need that kind of care. But not every bed has to be run by the NHS either. We've got, there are beds in the care sector and so on as in each community. Now, they vary in numbers too. We as a community have got to decide what we use the resources on and how we do it. I, for one, are not advocating cuts in beds because of money. I, for one, think we can make better use of the resource we've got, and I mean people resource and time resource, and have the right number of beds, but not too many beds either, because that wouldn't be good for us.
Yes, my name's Barbara Cotton and I'm a retired health visitor. I live in the Eden Valley. When you look at the map in front of the consultation document, Eden seems to finish at Penrith and Alston and doesn't extend down to Appleby and Kirby Stephen. We are quite short of services down the valley. The Upper Eden Valley Medical Practice got an outstanding CQC report, and our other GP practices also got good reports. So I feel that our primary care first contact is very good. But there aren't many more other services. We lost Edenside in Appleby, the care home there. Greengarth will close. Christian Head, which I do believe is a private nursing home, they've reduced their beds. There's only Stobers Hall and very little respite care. We've had 2 people from my village recently who've had very ill partners late on in the evening and have been asked to take those partners to Whitehaven. That's a long way from Kirby Stephen and from Appleby. Are there any plans to put more services into the area?
I think I'm probably going to come back to the same answer that I gave about this is about the communities, looking at the need for the people in those communities and moving and using the resource in the best way possible. So if that's where the need is, we need to work out how do we meet that need in the best way that we can, given what we have, because as Stephen's just said, we're not sitting on a pot of gold. There isn't a pot of gold, and there aren't millions of health visitors, nurses, beds, people just standing in the wings ready to come in and suddenly make everything right. So actually we have to work together to how we can do it as best we can together, and I think that's how it's going to work, because one person saying we're going to do it this way and then charging off on a white chariot and everybody else standing back going, I have no idea where they're going or what they're doing, is not going to work. It's literally holding hands together and going, actually, how do we do this so that those people don't have to go to Whitehaven? Because I agree with you, that is an awful situation to be in. And my dear hope would be that when we get the ICCs working properly, that would not happen.
Okay, thank you.
I wear another hat as well as a member of Cumbria Voluntary Services, and of course our voluntary sector, again, they're taking the fallout from health and from social services. They're in competition for volunteers, the same pot of gold of money, and also, again, down the valley and in other areas of Cumbria, we've lost voluntary organisations because of lack of volunteers, lack of funding. So this is another difficulty as well.
So it also, if you turn that, this is a big opportunity.
Oh, yes.
To actually really make a difference and do it right.
Yeah, so I've got 2 questions. The lady in the purple cardigan there, please. And then the lady there.
Hi, I'm Virginia Taylor. I'm also on the County Health Scrutiny Committee, so I've been sort of thinking about all this for a long time. It's, you know, I mean, I'm really heartened as a citizen power person that there seems to be, you know, that the leader of the ICC is the community itself, and that the community will decide and all the rest of it. And I would love that too, but the community doesn't hold the purse strings. And so we do need the organisations to step in and fund the things that people need, so that for example, the hospital beds, which is, you know, a big one. Every hospital bed that the NHS doesn't fund is either empty or somebody else funds it, and so that the wonderful plan that Alston, I'm not belittling anybody else's plan, put together has been received, and I believe is sort of like, seems to be a fantastic solution to difficult problems and issues. And there seems to be more that, you know, the community, we need the community to take those decisions. So this consultation is an NHS consultation. So you can make decisions for what happens within the NHS, but you can't make the decisions about what happens within Cumbria County Council and social care. And unless they're going to play ball, then this is going to not really work. And already we've had the issue of the care homes, where Cumbria County Council are really not thinking that care homes are a good thing to be supporting at this point. What they think is going to happen, I don't know. So I'm a district councillor, not a county councillor. The lady over there who's just talked about the school health and health visitors, that provision has now been taken over by the county. So the bits that the NHS did do are now done by the county. And that doesn't, you know, this lady has, you know, has felt that this looks like a reduction in services rather than a real sort of like community-focused, doing the best we can with the resources we can, solution to the needs. Now, I mean, I would hate to have to be a county councillor and have to actually make these funding cuts.
Sorry to interrupt you. I don't want to close you down, but we're coming up to nearly 3 o'clock. Can we get to the question, please?
My question is, how are you... it's really about the relationship with social services, and what are you going to do if they don't help?
Okay, thank you for that. I think the reason colleagues from social services aren't with us today is because what we are specifically consulting on are some very particular health changes that Stephen outlined. But we spent most of our time, which is particularly good news, I think, for both Rachel and I, talking about the potential of integrated care communities. And I have no doubt that my colleagues in not just adult social care, but children's social care are as keen and are working with us incredibly closely to be able to develop this concept. And it's something we've spent quite a lot of time, either Rachel will have done through trying to develop the integrated care community for Eden, that I'm doing working with colleagues to try and support all the 8 proposed integrated care communities for North Cumbria. We're spending a lot of time working jointly with our colleagues in adult social care, and I think the ambition's very much the same. I think you're right, the challenge is going to become how do we do that together? We need to change the way that we work together quite dramatically, I think, in Cumbria, to joining up how we use our resources and how we can put those budgets together so that individual integrated care communities can see the total resource that they've got and understand, you know, what choices they can make about how they use those resources in the future. But I don't feel anxiety about not having exactly the same ambition between us. I think that's there, and there's a big commitment to it.
Okay, thank you. Lady there, please.
Yeah, I think that, as opposed to anxiety, yeah, it's quite exciting, isn't it? I think we work, speaking as an NHS member of staff, really closely already with adult social care. And I'm sorry I was late, but I realise now there isn't anybody on the panel from adult social care, and I wonder, I might be speaking out of turn, but there's a huge team of health and wellbeing coaches been recruited recently, and I know from their remit that they will sit extremely comfortably with the ethos that we've got, you know, we're talking about here. My question is, the voluntary sector, we're I think accepting is a really valuable part of what we're talking about, and I just wondered how are the integrated budgets going to be shared with the voluntary sector?
Okay, thank you.
I'll come back to the same answer I've probably given 3 or 4 times. Actually, it's up to the community to decide. And I think those integrated care communities need to look at the resources, the skill mix, what's available, and look at the need of the people they're looking after and work out how you best, I hate saying the word spend, how you use those resources in the best possible way. And if that is growing those voluntary sectors, that is encouraging people to join, if that's going into schools and saying, how can we use the children to start to be doing some of that reduction of isolation for our older people? How can older people encourage children with their reading and to feel part of a community? That's all on the table. And I hope more and more of it's on the table that I haven't even thought of yet, because that's the knowledge in the community will come very much from those voluntary groups.
That's good. Yeah, that's fantastic. That's what I want to hear. Can you touch on exactly how that's going to happen then? sort of in each community. We're getting down to the nitty-gritty, aren't we? How can I picture that happening?
I could pass the buck now and say that we have integrated care community managers who are going to be working very closely. I can see Angie smiling at me from the second row, if you want to point out. I could make her put a hand up if you want me to. But we are working on that. Obviously, this is a big part of how we move forward and getting it right. And any sort of ideas and thoughts, I'm more than happy. My email's probably somewhere on the documents. You can find me anyway. Those of you who know, I'm at the Lakes Medical Practice, so I'm more than happy to receive ideas and thoughts, and I will pass them to somebody who can do something with them.
I'm going to just make a commitment that we're coming up to the finish, and I'll let Stephen speak, but I'm sure the panel aren't running away by this, and they will be available to speak to you if you've got any concerns after this. Stephen.
Two things. It's a kind of learning experience on both sides, this, as to how to get there. And one of the things we've done in the last 12 months is look at how Millham managed to form their alliance in their community to direct the way things should change. And taking the lessons from that sort of community-led collective leadership and using that to help the emerging new communities in places like Workington is one we're working with, and so on and so forth. So we're passing the lessons of how people have done it before, because we're learning on both sides. And, you know, as a final positive point, I was in a church in Maryport on one evening last week, and there was active recruiting going on in the meeting for a new alliance for Maryport to make these sorts of decisions and so on. And that's fantastic. And that's... both sides, I think, are learning how to do this better, because it's not a traditional way of taking decisions in Cumbria. So we've got to feel our way forwards.
Okay.
Obviously, I'm representing the Acute Trust or the Hospital Trust. I can just say that we've absolutely fully support the development of the ICCs. The specialists in the trust have a role to play in the ICCs in supporting more care being taken place out of the hospital. And certainly where these types of things have taken place elsewhere in the country, it's been vital in making sure that the best advantage is taken of that. And I just really wanted to say that on behalf of the Trust.
Thank you very much. I'm going to take some last questions very quickly, because I need to wrap it up. So we've got one question there. I'm going to take three if there is. Can you just wait?
Where are your integrated communities going to be? Because you've not published anything yet.
Now you're going to test my memory. There are proposed to be 8 integrated care communities across...
Well, can you put that in the press and so the general public know?
Yes, I'm sure that's a really good point. We can make that information more widely available. Thank you.
Yeah, okay. Any last questions before we wind the meeting up? One very briefly there at the back.
Yeah, I'm quite a customer of the NHS. You talk about healthcare for the future. Can you explain what the future is for Carlisle Hospital when it's on a PFI contract, please?
I think the future of the Carlisle Hospital is really strong. I think a lot of the changes that Stephen described to the services at West Cumberland, actually the changes are just as significant for Carlisle to be able to deliver the highest quality services for this patch. The PFI, we work closely with the PFI. We'll be making sure that the estate is adapted, adjusted to make sure it can deliver that. I mean, what more can I say, except we are working more closely with the PFI company and the estates than perhaps has been taking place previously.
But I'll need to close it off, so one last follow-up here. Can you just...
That really wasn't my question. I understand that the PFI contract is a 25-year contract. We're already 2/3 of the way through that contract. So what is the future for Carlisle, please?
So the future for the Carlisle after the end of the PFI contract?
Yeah, it's costing £20 million a year over 30 years. The rent just for the people flipping out.
I don't want to get into a political discussion. My understanding of the way the PFI works is that's one of the choices for getting the capital to build new hospitals, and I think we all want the hospitals to get rebuilt as they're needed. The lease, as you say, is 25 years. Actually, Cumbria doesn't pay the additional cost of that lease, that's a national allocation. So I know there's lots of rumours in the community that we're bankrupted because of the PFI. We already get a special allocation to cover the additional costs of that lease. There are other ways of doing capital programmes. West Cumbria Hospital was built a different way. And, you know, the life of the hospital is about how we negotiate contracts for leasing buildings, just like your local GP surgery could be leased. Many of us, me included, live in renting accommodations. We have to renegotiate our contracts.
Yeah, it's over 30 years.
Sorry, can you wait until...
Yeah, it's over 30
Hang-
years and it costs them £20 million a year for 30 years. It isn't over 25
But
years.
there's no such thing as free money. If we built anything, you have to pay the revenue consequences of the capital.
Of course, yeah, but PFI stands for poor idea, doesn't it? Poor flipping idea.
It stands for Public Finance Initiative, as you well know.
Yeah. Okay, thank you for that. Call the meeting to order. I don't want to end it if anyone feels that they haven't had the opportunity to speak. But unless there are any last questions, all that remains to do is to thank everyone in the audience for giving up your time to attend. Thank you for the excellent questions and the enthusiasm and passion that's shown through. And I'd also like to thank the panel for taking those questions and responding as they have. So thank you very much, and we'll call the meeting to an end. Thank you.